Professor Andrew, he is a pediatrics immunology and hematologic stem cell transplant at the University of Newcastle upon Tyne and honorary consultant at the Northern Super-Regional Bone Marrow Transplant Unit for SCIDS and related disorders. Probably you already see the name of Andrew appeared twice during the presentation of Dr. Hiba, helping in classification and diagnosing the patients with the SCIDS. He spent a year postdoctoral studies working with Alan Fisher and Anne Dorandi in the Necker Hospital in France, and involved the discovery of cytidine deaminase, one of the first genes to be discovered involved in class switch recombination and somatic hypermutation. Professor Andrew, if you can hear me, please, you can start your presentation now.
Thank you very much, and I hope you can see my screen and you can hear me okay?
We can hear you, but we cannot see you.
No, well, I've turned my camera, I've turned the camera.
Fine, okay, we can see the presentation.
You can see my presentation, fine. So I'm, first of all, thank you to Hiba and to the organizers for asking me to speak. I really wish that I could be with you. It would be great to be doing face-to-face meetings again, and I'm sitting in my living room at the moment. It's 4 degrees outside, it's windy and it's raining, so there are many reasons why I would like to be with you, not least of which is the weather. I've been asked to talk about transplant and gene therapy for primary immunodeficiency, and I'm actually going to concentrate on transplant, but I'll give 1 or 2 remarks about gene therapy. So I have previously had research funding from Jazz Pharmaceuticals and from Mallinckrodt, but actually that's not relevant for any of my talk today. So as a pediatrician, to be honest, I feel fairly proud about the place that we play in the history of stem cell transplantation. I think you could convincingly argue that we really kick-started bone marrow transplantation as a therapeutic procedure back in 1968, when there were 3 patients transplanted, 2 with X-linked SCID and 1 with Wiskott-Aldrich syndrome. In the beginning of the 80s, T-cell depleted transplants were introduced again, initially in children. Cord blood transplantation was introduced initially for a child with Fanconi anemia. And then, not on this chart, but more recently, the first licensed gene vector for gene therapy for ADA SCID was licensed in Europe to treat ADA SCID. But also, you may or may not recognize this little boy who had Wiskott-Aldrich syndrome. His name was Anthony Nolan, and I'm sure you will recognize the name. He didn't have a brother or a sister that was matched to him, and therefore he wasn't able to undergo transplantation, and sadly he died of his disease. This was in the days before we had matched unrelated donor registries, and in honor of this, his mother set up the first matched unrelated donor registry, the Anthony Nolan Register in London, which was the first time that we started to start a register where donors could put their names forward and could donate for people that they were not related to. And now, of course, unrelated donor registries are around the world, and there's over 40 million donors on those registries. So a tragic story, but actually had a tremendously good outcome from that. So the ideal aim of transplantation for primary immunodeficiency, and indeed for gene therapy, would be that it is safe, that you have a permanent correction of the defect, that you have long-term immune reconstitution, that there are no long-term side effects, and ideally that you need no additional long-term treatment. And what I'm going to do is, it's a really big topic and I've only got 25 minutes. So I'm going to cover severe combined immune deficiency. I'm going to cover a neutrophil defect, a combined immunodeficiency defect, and a syndromic combined immune deficiency defect. But actually we transplant for most of the categories that Hiba was talking about earlier. We don't do it for the phenocopies, and most complement disorders don't get transplants, but it's possible to transplant diseases in pretty much all of the other categories. This is a fairly old slide now, but it shows you the different genetic abnormalities that can lead to severe combined immune deficiency, because the gene defect leads to the early interruption of T cell development, plus or minus B cell and or NK cell development. And if I can just interject on the discussion about genetic screening, whole exome screening is great, but unfortunately it takes a little while. And I think if you are very clear what the broad diagnosis is, such as it looks like SCID or it looks like chronic granulomatous disease, then I would argue it is better to go for a panel where the turnaround time may be only 2 or 3 weeks, rather than whole exome sequencing where it might be 2 or 3 months. And that might be important, particularly in SCID, because you might want to be moving forward quickly with transplantation. So one of the first transplants in 1968 was in Europe, in Leiden, for X-linked SCID. And since then, at the SCETID registry in Paris, we have been collecting data on transplant for primary immunodeficiency. And at intermittent periods, we publish these data. This was the first publication in 1986, and this was looking at the outcome of patients transplanted with severe combined immune deficiency. Not a lot of patients at that stage, just about 200 or so. But you can see that for patients who had an HLA matched donor, we had a survival of almost 70%. For those with an HLA mismatched donor, which was T-cell depleted, it was closer to 60%, with all comers around 60%. Somewhat surprisingly, some of the HLA mismatched were not T-cell depleted, and almost 20% of those survived, which I'm stunned at, that it's as many as that. But I don't know what the HLA mismatches were in that situation. And over time, for a whole number of reasons, including better matching, early diagnosis of SCID, better conditioning regimens, better supportive treatment through transplant, including antimicrobials, detection of infection with things like viral PCRs, and better supportive treatment, things have got much better. These are data from the latest data set that has been published, and in fact I think has only recently come online in JACI earlier this year. And this was looking at overall survival between 2006 and 2014. But rather than looking at SCID or T minus B plus or T minus B minus SCID, we were actually able to group patients due to an actual genetic diagnosis. And what's been interesting, so for a number of years, we knew that T minus B plus NK minus or T minus B plus NK plus SCIDs did better than T minus B minus NK plus. But now that we have genetic diagnosis, actually there is no statistical difference in survival between the different genetic causes. Although there are clearly on the line differences, it's not statistically significant. There are some differences depending on whether we use a mismatched related or a mismatched unrelated donor, and the mismatched transplants, which are generally T-cell depleted these days, do worse. Matched is actually matched sibling or matched unrelated donor, because there is no difference these days between a matched unrelated donor and a matched sibling donor. I'm actually going to argue there's no difference between any of those donors, and I'll show you those data in a minute. When we looked at different genetic types, and we looked at whether they'd had conditioning or myeloablative or reduced intensity conditioning, there was no difference in survival. And I think that's important, because I think there's for a long time been a debate about whether we should condition SCID babies or not prior to transplant. And I think the pendulum these days is swinging that we should, and certainly in terms of survival, there's no difference if you do. When we look at event-free survival, there doesn't seem to be any difference for the common gamma change ACT3 and IL-7 receptor alpha SCIDs. When we look at the RAG or the Artemis SCIDs, again, there's no difference in survival between conditioning and no conditioning. And although it's not quite statistically significant, there is a difference in those that are conditioned and those that are not conditioned in terms of event-free survival. And I think the problem with this particular type of SCID is that if you don't give conditioning, you don't get stem cell engraftment, and you only get peripheral T-cell engraftment, and you're likely to end up with a poor graft. You're more likely to get graft versus host disease. You're more likely to get graft failure, and you're more likely to need a retransplant. The other important thing that we showed in this manuscript was that actually it's important to have at least about 500 naive T cells in order to become independent of immunoglobulin transfusions post-transplant. And really the way to get that number of naive T cells is to give conditioning. And that's the first time I think that in the SCID papers we've been able to demonstrate this. Now that is important because there's a study that we did a number of years ago now with one of my PhD students from Malaysia, where we looked at our own cohort and we were able to show differences in the quality of life between patients that were requiring ongoing immunoglobulin replacement and those that were on no medication. And those on no medication essentially had a normal quality of life, and it was reduced in those who had an ongoing antibody replacement need. Perhaps not surprising, but it was the first time that that had been shown. And in the same study, we also showed the importance of conditioning in terms of long-term immune reconstitution. And those patients that have been conditioned, and this was for the common gamma chain JAK3, IL-7 receptor alpha, RAG1 and 2, and Artemis patients, the top line in each of these graphs is the naive T cell output or the thymic output in conditioned patients, and in the bottom it's the naive T cell output in those that are not conditioned. And you can see that over time, and even right at the beginning, it's much better if you're conditioned, which is much more likely to lead to a long-term immune reconstitution. So I've shown you this graph already, and it was really just to remind you that T cell depletion is not as good as matched HLA transplants, either unrelated or related. But actually, methods of T cell manipulation and marrow manipulation have really evolved quite an extraordinary way. And these days, I don't think there's any difference depending on the donor that you use. And it's really all to do with the condition of the child at transplant. These are data that we have revised and resubmitted for publication from our own cohort. And at the top, you can see in red T cell depletion, in blue is the matched unrelated donors, in pink the matched family donors, and in green the cord bloods. And statistically, there is no difference in survival depending on the donor source. And the same is true, statistically at least, in terms of the risk of getting graft versus host disease. So I would argue today that actually the donor isn't the important thing, but it's really the status of the child, the clinical status of the child when we come to transplant, which leads on to the next question: when should we transplant patients with SCID? And the short answer to that is as soon as we possibly can. These are data from a study between ourselves in Newcastle and Great Ormond Street, where we looked at families where there was more than one child affected with SCID. The first child, the proband, we didn't know the family. The patient often turned up late and sick when the diagnosis was made late. And then in subsequent children, we were able to either do an in utero diagnosis or more commonly diagnose at birth and take to transplant. And you can see that the survival in the proband group versus the newly diagnosed group was really very different, 54% versus 93%. And the reason for that, of course, is because if you're diagnosed at birth, then you're much less likely to have infection when you come to transplant. And these data are from the PIDTC group in North America, but really show the same sort of thing, that when you have no active infection at transplant, you have a much better chance of success, whatever the donor, than if you have active infection at the time of transplant. And really, it's these data that have pioneered the way for newborn screening of SCID using the TREC analysis, which I know is taking part in many countries. And in the UK and England, we've just started a pilot to evaluate the test. I'm going to move briefly on to gene therapy. And the reason for only briefly is because a talk on gene therapy could take half an hour at least in itself. But also, largely, it's still an experimental therapy. For ADA SCID, it is now one of the standards of care if you don't have a matched donor, and particularly a matched related donor. And these were data put together from a publication from the Milan group, where the licensed vector is given. and comparing it with transplantation. But these are historic transplant data. And one of the problems we have when we're comparing transplant outcomes with gene therapy outcomes is we're often looking at really quite old data for transplant. And as I've already showed you, some of the new data is really much better indeed. And so the advantage of the gene therapy was that there was 100% survival. Now, I'm a transplanter, so I'm a little cynical about some of this because I think they're quite selective sometimes about which patients are able to come to gene therapy. And some of them who are too sick go on to have a transplant instead. And now you'll know that with some of the other diseases, with the gamma retroviral vector, there was an incidence of malignancy or lymphoproliferation or myelodysplasia. And because of that, we've changed over to the lentiviral vectors. Now, this isn't a licensed vector, but these are data from a parallel study in the US and the UK, again showing really very good survival for ADA SCID gene therapy using the lentiviral vector. And one of the things that's been quite surprising in ADA SCID is that although all of the other diseases that used a gamma retroviral vector developed the myelodysplasia, lymphoproliferation, or malignancy, leukemia, we hadn't seen it in the ADA SCID. But there is actually now a report of one of the patients who quite a long time after gene therapy has developed a leukemia-like illness. The other issue, I think, with gene therapy is the cost. And for ADA SCID, it's about 600,000 euros. For a transplant for ADA SCID, it'll be about 200,000 euros. And also at the moment for the ADA SCID, you have to go to Milan for the treatment, whereas of course a transplantation is available in many different centres in different countries. And again, just to put this into some perspective, we're just publishing our ADA series at the moment. This is again in revision, has just been resubmitted. And these are our results in 23 patients. It's the entire cohort. Now we split it before and after 2007, because in 2007 we started using treosulfan rather than busulfan as part of our core conditioning agent. And you can see that since then, which is 21 patients, we have 100% survival. The other thing that we started doing is using the enzyme replacement therapy, PEG-ADA, to rehabilitate patients before we take them to transplant. And that helps reduce any inflammation and allows them to gain weight and actually sometimes to clear infection. You may or may not be aware that there's a new artificially produced form of PEG-ADA, the Ella-PEG-ADAMase, which is not made from a bovine source, but is, I think, produced from bacteria. It's a bit more expensive and actually possibly a little bit more potent. And that's really something just to be aware of. The patients that we've started on this, and it's actually replaced the old bovine formulation, have often had quite rapid immune reconstitution. And in those that have had BCG vaccination, it's led to BCG reactivation. So that's just a kind of note of caution. I'm going to move on and think about transplantation for other primary immunodeficiency, chronic granulomatous disease, Wiskott-Aldrich syndrome, and finally CD40 ligand deficiency. This was a study from the Inborn Errors Working Party that was published just, well, it's a couple of years ago now, just, it was a large study of over 700, mainly children, but there were some adults. And you can see that the overall survival for transplant is 85%, and that's to at least 3 years follow-up. Interestingly, when we looked at survival by age, perhaps unsurprisingly, those that were transplanted as children did better than those that were transplanted as adults, and that was a significant difference. But as one of my adult colleagues has told me, in adult land, a survival of 75% or more for any one particular disease that's being transplanted, they think is exceptionally good. So even if you do have adults with CGD, it may be worth considering transplantation for those patients. When we looked at donor type, again, there was a difference between the mismatched donors at the bottom and the matched donors at the top, although actually our own data don't support that. So this is a study that we published just a couple of years ago also from, again, our CGD cohort of 55 patients, many of whom were in the Big Inborn Errors Working Party study. You can see that our 5-year overall survival is 90%. But when we split it by age, at less than 5 years and at more than 5 years, you can see that we have 100% survival in those that are 5 years or less, and drops down to 80% in the older patients. And the reason for that, of course, is not the age per se, but it's that the older patients have more comorbidities with inflammatory disease and persistent infection, particularly fungal infection. And then the other important feature from this study was when we looked at our donor survival, there was no difference statistically between haploidentical donors, unrelated donors, and family donors. And we've done, I think it's over 10 patients now using T-cell depleted donors, and to date we still have 100% survival for those patients. So I would argue today that when we're thinking about transplant, the issue is not the donor, the issue is the patient and the comorbidities that they carry. And then this is just another of our studies from a few years ago now, where we looked at the UK cohort and we looked at those that hadn't been transplanted, and we looked at those that had been transplanted. This is in children, and in those that had not been transplanted, their quality of life measured by parents and by the children was lower than the UK age-related norms, whereas in the post-transplant patients, the quality of life was normal and it was comparable to the age-related norms. And when we compared post-transplant and non-transplant, there were significant differences between them, with the transplanted patients doing better. I'm going to move on to Wiskott-Aldrich syndrome. These are extraordinarily new data. They actually only came online last week. This is the Inborn Errors Working Party data for transplant for Wiskott-Aldrich syndrome. You can see the overall survival is about 90%. And that there was no difference in survival when we used busulfan-fludarabine or triasulfan-fludarabine as the conditioning regimen. There was a slight difference in the incidence of graft failure, which was higher with triasulfan-fludarabine, although it was not a significant difference. Again, we didn't actually see a difference when we looked at the donors. So matched sibling, matched family, unrelated and mismatched family with T-cell depletion. Although there are clearly differences on the curve, that was not significant. And again, has been shown previously and confirmed in this study, there is an age difference with survival, and the survival in patients at 5 years or less was better than those that were transplanted beyond 5 years. And again, it's not the age per se, but it's the comorbidities that these patients are carrying. And then finally, I just want to talk about transplantation for CD40 ligand deficiency. Again, this is a big study that was published 2 or 3 years ago now, and it was an Inborn Errors Working Party, SCETID, and a North American study. So it was a big multi-center study. There were 130 patients from 36 transplant centers worldwide. And there were a number of messages that came out of this. Now, this is a fairly complicated graph, but transplanted since the year 2000. And the year 2000, we often use as a magic year in transplantation because there were many things that were getting better at that time. Our accuracy at HLA matching was improving. Our antibiotics and antivirals were improving. We were able to do preemptive treatment for viral infection because of viral surveillance by PCR, and a whole number of other things that just made transplant safer. And you can see that the group that did best were less than 5 years old, transplanted after 2000, followed by those that were who were older and transplanted after 2000. And then again, it's the older age groups that tend to do badly. And then going hand in hand with that really was the fact that those patients who had no organ damage did better with transplant than those patients who had pre-existing organ damage. And the biggest issue actually was liver damage, but also lung damage. And then the other thing that we found that was important was that if you had viral infections during transplantation, then you were more likely to end up with mixed chimerism after transplantation. And that's probably quite important, because if you get a very low level of donor chimerism, you're more likely to need, for instance, antibody replacement, even if you are able to control things like viral infection and cryptosporidium. The same we actually found when we looked at the Wiskott-Aldrich syndrome patients. Previously, there was a kind of signature that mixed chimerism led to an increase of autoimmunity. We didn't really find that in the big inborn errors study that I've just shown you this time, but it might be either to do with the length of follow-up or the number of patients. And again, in chronic granulomatous disease, if you get certainly significant mixed donor chimerism, then you've actually converted the patient, if you like, to looking more like an X-linked CGD carrier. And we know that X-linked carriers can have disease with recurrent infections, but more particularly with autoinflammation and SLE-like disease. And so the higher the chimerism that you can get, the better that is. And so the key messages from the CD40 ligand study was that transplant can be curative, best performed before the age of 10 years if you don't have organ damage, and particularly if you don't have sclerosing cholangitis. Superior overall survival with matched donors, transplantation early after diagnosis, and use of myeloablative rather than the reduced intensity and non-myeloablative conditioning led to better outcomes. And then just finally, again, these are new data from our own center that we've only just published. There's 23 patients here. This is our CD40 ligand cohort. And you can see that since 2000, our overall survival and our event-free survival are 100%, whereas before 2000, we have a much worse overall survival and event-free survival. And again, it's really to do with the fact that these patients we're now picking up earlier and bringing to transplant earlier. So it's a pre-existing organ damage that's the big issue. And that CD40 ligand expression actually correlates, perhaps unsurprisingly, with donor T lymphocyte chimerism. So I'm going to finish there. I think overall and event-free survival is improving both in SCID and non-SCID primary immunodeficiency. That the outcomes for SCID are not genotype dependent, but actually depend on the condition of the child at transplant. And that for best results for chimerism in SCID, you really need conditioning for a good long-term immune reconstitution. For other diseases, probably you get a better outcome with better chimerism. And that's one of the reasons that I've not dwelt on gene therapy for other diseases, partly because apart from ADA SCID, all of the other gene therapy are still in clinical trials, but actually also because apart from SCID, where actually it doesn't matter if you don't get complete donor chimerism, 10% donor myeloid is probably good enough to give you long-term immune reconstitution. But in others like Wiskott-Aldrich, like CGD, like CD40 ligand, then actually having good donor chimerism is important, I think, for good correction of the disease. And currently in gene therapy, we're lucky if we're getting 10 or 20% inverted commas chimerism, gene transduction, which is equivalent. And therefore, I think gene therapy for some of these other diseases, we really need to debate where it fits in the treatment algorithm, because I think if you've got young, healthy children, actually transplantation is going to give you a better outcome and is safe. So we have improving results for non-SCID primary immunodeficiency as well as for SCID, and younger patients do better. So if I've got one message to you as non-transplanters, it's going to be refer these children early, because then they have the better chance of survival and long-term cure. Thank you very much.